Alors, je vous souhaite la bienvenue, tout le monde. Cette séance a lieu en anglais. Ce sera interprété en français. I would invite all of you to use the C-Event app for your comments and questions. And we can interpret your comments, whether they be in English, French, Spanish, or Italian. I would remind you to wear a mask in the room. You are encouraged to wear a mask. My name is Anna Towers. I'm a physician in palliative care at the McGill University Health Center. I am moderating this session, and we have three experienced, distinguished speakers who I will introduce in a moment. During the plenary, you heard Ira Byock speak about our brand. I've been doing palliative care for 30 years, and for the first 20, 25 years, I knew what our brand was, and the problem was only how do we communicate this to patients, families, and the community. I used to know. And now I don't anymore, and it's causing moral distress and also intellectual curiosity, like what is going on? And we have a lot of why questions and what is going on. It's a changing field. For those of you outside Canada, just to tell you that it's been 7 years since the Supreme Court in Canada struck down the criminal code provision against MAiD, which is euthanasia or assisted suicide. In Canada, it's mostly clinician-administered lethal injection, and rarely it's assisted suicide where we provide the patient with the medication. What have been the changes in the last 7 years? Well, originally, this was for those where the death was reasonably foreseeable. Now it's no longer, so anyone with chronic illness or disability can ask for MAiD. As of March 2023, next year, patients whose sole underlying medical condition is a psychiatric disorder, a mental illness, can ask for MAiD, although that was appealed in Quebec. We'll see what happens next year in Quebec and the other provinces. Also, we've seen the removal of certain rules, or some people would say safeguards, in the interests of increased justice, fairness, access. 2 witnesses is down to 1 witness. There's been the removal of the 10-day waiting period for those at the end of life, because often they would become delirious, and it was felt it was not fair to not offer them what they asked for. So it's very complex. What is our brand? So we need more research. We need narratives. We need witness accounts. We need qualitative and also data. We need quantitative research, what's going on. So there's this intellectual fascination for those like me. I want to know what's going on. I want to know why. At the same time, there's this moral distress. Those of us that are on consultation services have seen 100, 200 cases of patients asking for MAiD, many of them receiving MAiD. So it's at the same time exhausting, it's stimulating. And the other problem is, at least in the context where I am, we don't talk about it. Why don't we talk about it amongst ourselves? It's arguably the most important thing that's happened to us in the last, well, since palliative care was defined. We don't talk. As our colleague Deborah Dudgeon said to me the other day, yeah, we do talk, but we don't listen. So today let's try and not only talk, but also listen. I'd like to introduce our speakers, who arguably are some of the most experienced palliative care physicians in Canada. Our first speaker will be Leonie Herx, who's division head of palliative care at Queen's University, and she's past president of the Canadian Society of Palliative Care Physicians and has done a lot of thinking regarding MAiD. The second speaker is James Downar, who's head and professor of the Division of Palliative Care at the University of Ottawa, an esteemed researcher who also has done a lot of thinking on the subject. And lastly, my dear colleague Golda Tradounsky, who's the long-suffering program director of palliative care and who has kindly offered to continue providing this service for years and years. So we'll start with Dr. Herx, please.
I'm at that age in my life where I now need multifocal glasses, but I ordered them and they haven't arrived. So I will be wearing my reading glasses and peering over the top of them at you. I also wore my very tall shoes today so that you could see me over the podium. So thank you so much to the Congress for having us here today and to open up a forum for dialogue on this critically important topic. It is, very divisive, and it shouldn't be. We need to be able to talk about it and come together as a community. So I'm very grateful to be here and to have this honest, open, and respectful dialogue. I'm here today on behalf of the Canadian Society of Palliative Care Physicians, and as you heard, I'm a former president. If I'll just move on to, if I can get this thing to work, perfect. So I don't have any conflicts of interest, but just to disclose, of course, that I am a past president for CSPCP, and I've been an expert witness to 3 parliamentary committees studying expansions of MAiD in Canada in 2020, 2021, and recently in 2022. So what I hope you'll get out of my presentation today is to really think about the distinctions between MAiD and palliative care. I hope to show you how MAiD and palliative care continue to be conflated in Canada, go through a little bit about the Canadian MAiD context, including what we do and do not know about access to palliative care in those who receive MAiD and the nature of suffering in those who receive MAiD. And I'll spend most of my time talking about the impacts of MAiD on the clinical practice of palliative care. I won't have time to get into much about the education components, although I will note that both James and I are former program directors of palliative medicine training programs as well, so all 3 of us have an education background here today. And of course, we'll end with some recommendations that we hope other countries can learn from us and the experience we've been having. For CanMeds, I just put the whole competency framework up because it actually, we're going to be touching on all of them. This is such a holistic issue, as is palliative care, so we'll be really covering all of them. So Anna has already walked us through the background, so I'll just very briefly say that in 2016, Canada legalized assisted suicide and euthanasia for Canadians with a reasonably foreseeable death, calling it medical assistance in dying, or in Quebec, medical aid in dying. Since then, we've seen an exponential increase in MAiD deaths and expansions in MAiD eligibility through progressive interpretations of the law, and in March 2021, legislative revisions that allow MAiD for suffering due to any chronic illness, physical illness, or disability, and as of March 2023, mental illness as a sole diagnosis. Safeguards were seen as obstructions to accessing MAiD and were removed in March 2021 for those with a reasonably foreseeable death, including a 10-day waiting period and the requirement for capacity and consent at the time of lethal injection. So you can now have what's called a waiver of final consent. The Canadian Society of Palliative Care Physicians warned about the potential for normalization of death by euthanasia and ensuring safeguards, and we continue to submit and present to the federal government as recently as June 2022 as part of the government's statutory review on MAiD. If I can get the slides to work, we'll be in good shape. Okay. I'm going to talk a little bit now about the distinctions between MAiD and palliative care. Palliative care is a holistic approach to care that focuses on enhancing the quality of life for persons living with serious life-threatening illnesses and their families. Clinically, we do this by means of early identification, impeccable assessment and treatment of symptoms, including physical, psychosocial, and spiritual concerns, to support a person in living well until they die. Medical aid in living, or MAIL, if you will. Palliative care has worked for over 40 years to reassure patients, families, and healthcare providers that we do not hasten death or shorten someone's life, for example, when we give them opioids or other medications as part of their palliative care symptom management. the Canadian MAiD legislation legally distinguished MAiD and palliative care by positioning palliative care as a general safeguard for informed consent to MAiD. Thus, conflation of these two distinct practices means palliative care is no longer the safeguard for MAiD. I want to point out that palliative care is internationally recognized as a practice distinct from MAiD, and I've listed a number of the associations here. Palliative care is not part of the scope of practice or competencies for specialist palliative care physician training. In either of our two credentialed training programs in Canada, the College of Family Physicians 1-year Enhanced Skills in Palliative Care and the Royal College Palliative Medicine 2-year subspecialty, what we do recognize in the competencies and scope of practice of specialist palliative care physicians is the very unique role that we play in understanding and addressing the complex nature of suffering, coming alongside and working in a team-based approach to enhance dignity and personhood in keeping with Cicely Saunders' concept of total pain and total suffering. I'll also point out that the Canadian Medical Association recognized palliative care and MAiD as distinct in their palliative care policy. As I mentioned earlier, in Canada, we continue to see a conflation of MAiD with palliative care. The deliberate use of terminology, medical aid in dying or medical assistance in dying, has confused MAiD and palliative care in the public and in other healthcare professionals' minds. The Canadian Hospice Palliative Care Association and CSPCP, our Canadian Society of Palliative Care Physicians, jointly advocated against the use of this euphemistic language, arguing that palliative care aids those who are dying in order to help them live as fully as possible until their natural death, but does not intentionally end life. This statement was endorsed by international palliative care organizations, many of which I listed on the slide previous. Despite this clear distinction between palliative care and MAiD, some MAiD proponents continue to push for MAiD to be seen as part of the continuum of palliative care and refer to MAiD as an extension of palliative care or as another tool in the palliative care basket. This misrepresentation has been further perpetuated by federal politicians who do not understand palliative care. And politicians continue to hear this confusing messaging. In a testimony just this week, to the Parliamentary Committee studying MAiD, Dr. Madeleine Lee, a MAiD provider and psychiatrist at the University Health Network in Toronto, said to the committee and the politicians who were responsible for lawmaking in our country, everything in MAiD up until the last 5 minutes is palliative care. I assume she means the lethal injection as the last 5 minutes. In the recent 2022 Canadian Society of Palliative Care Physicians submission to the Joint Parliamentary Committee studying MAiD, we stated that conflating palliative care with MAiD ensures palliative care remains associated with end of life, and this has created unnecessary and unintended barriers to the integrated and timely access of palliative care services that are needed early in the disease trajectory. Another example of MAiD conflation with palliative care is the positioning of palliative sedation therapy as an alternative to MAiD. For example, if a person does not have capacity. Palliative sedation is not an alternative to MAiD. It is a specialized palliative care intervention to be used according to rigorous guidelines with meticulous monitoring for effect and side effect. It is delivered proportionately to alleviate refractory symptoms in the last hours or days of life when all the other options to control symptoms have been exhausted. Palliative sedation is not, I repeat, not on a spectrum with MAiD. Unfortunately, palliative care remains woefully underfunded and inaccessible to many people who need it. Only about 30 to 50% of Canadians have access to some kind of palliative care of unknown quality, and very few, only about 15%, have access to specialist palliative care to address more complex issues. You are less likely to receive palliative care if you're poor, Indigenous, homeless, incarcerated, or live in a rural area. We lack useful indicators of the quality of palliative care, as well as national standards for the provision of quality palliative care. Meanwhile, MAiD is expanding its criteria in the face of inadequate palliative care and a worn-out healthcare workforce, and has received extensive support from the federal and provincial governments, unlike palliative care. The Canadian Society of Palliative Care Physicians has expressed ongoing concern that continuing to expand MAiD without investing in the necessary resources to support universal access to palliative care negatively impacts patient outcomes. Tragically, there are far too many patients in our practices who have opted for MAiD due to lack of adequate palliative home care resources to remain in their homes or home communities. This lack of access has been amplified by home care staffing shortages seen during the COVID-19 pandemic. The CSPCP strongly advocates for universal access to high-quality, comprehensive palliative care to address the suffering experienced by patients with life-threatening illness and their families. No one should feel compelled to choose an early death because of inadequate care at home. MAiD advocates will assert that MAiD is not driven by a lack of access to palliative care, citing, such as you can see here, Health Canada reports, this one being the third annual report on MAiD, which shows the deaths of about 10,000 people from 2021. And you'll see in the top there that 80.7% of MAiD recipients were reported as receiving palliative care services. However, it is important to note that these reports are based on self-reporting of MAiD providers, and there is no information regarding the quality or quantity of palliative care, including who provided it, the frequency and type of contact, and with what expertise. We have no defined minimum threshold for what constitutes, quote, receiving palliative care in any of the Health Canada reporting. Indeed, even the Health Canada report itself now has added a disclaimer this year. Quote, however, this result does not offer insight into the adequacy or quality of the palliative care services that were available or provided. Even with these significant data limitations taken into account, we can see that the Health Canada report suggests problems with access to palliative care. 16.8% received no palliative care at all, and about 38%, so 21.4%, received palliative care within 2 weeks of MAiD, and 19% within 4 weeks of MAiD. So that's, well, if I take the no palliative care and the 2 weeks of palliative care, that's over 38% of those receiving palliative care that had little to no palliative care. Some may say 4 weeks is even much too few. MAiD proponents will also say that the Health Canada access data shows that the 16.8% who did not receive any palliative care, of those, 88% had, quote, access to it if they wanted it. But we have no idea what that means at all at the patient level. We don't know what they were told about palliative care, what they knew about palliative care, or when it was offered. If palliative care was only offered at the time of MAiD request, that is far too late. People have made up their minds after months of unaddressed suffering. It's very difficult to change their minds. Offering palliative care after a person has chosen MAiD risks refusal by the patient due to fears that the palliative care team will try to dissuade the patient from undergoing MAiD, or that they might not be eligible if their symptoms are relieved. This is already the case in Belgium, where a referral to a palliative care after a patient has chosen euthanasia is seen as obstructing euthanasia. A similar experience was described by Dr. Jose Pereira, a colleague who's head of palliative care at McMaster University 2 weeks ago when he testified to the Joint Parliamentary Committee studying MAiD. He reported that he was prevented from providing palliative care to patients admitted to the palliative care unit to receive MAiD, who he felt had unmet palliative care needs, and he was made to feel like he was blocking access to MAiD. Based on how Health Canada is currently collecting data, a patient suffering for 2 years without any palliation whatsoever, then admitted to a palliative care unit to receive MAiD, would be designated as having received palliative care. This means that the data we currently have is at best deeply flawed, to at worst meaningless. Another study often referenced to reinforce that MAiD has nothing to do with access to palliative care reports on the early experience of MAiD in Ontario by Dr. Downar and colleagues in CMAJ 2020. That study indicates that palliative care providers were involved at any point in the care of 77.2% of patients receiving MAiD, and at the time of the request for MAiD in 74.4%. But like the Health Canada report, this study reports the involvement of palliative care of any kind without any specificity regarding what that means. Was that the MAiD provider themselves who considered that they had provided palliative care? Was it a one-time visit with a social worker? We don't know. This is akin to reporting how many people took a drug while neglecting to provide the dose, route, and duration of administration. So is the lack of palliative care driving access to MAiD? We simply don't know, and we cannot draw any meaningful conclusions from the type of data that's being collected. Reasons that people request MAiD in Canada. MAiD proponents argue that MAiD requests in Canada are not primarily driven by physical suffering, but are driven by existential suffering, which they say palliative care has limited ability to address. This argument is meant to neutralize the potential influence palliative care might have in mitigating suffering that manifests as a wish to die. In this third annual report on MAiD from Health Canada, which you can see up on the screen, you can see the main sources of intolerable suffering as reported by the MAiD providers. Number 1 is the loss of ability to engage in meaningful activities. Number 2 is the loss of ability to perform activities of daily living, followed by inadequate pain control or concern about inadequate pain control, loss of dignity, and inadequate control of symptoms or other pain, again, or concern about it. They're not differentiated. MAiD proponents have characterized these top 2 as existential suffering. However, the loss of the ability to engage in meaningful activities or activities of daily living implicates various and diverse challenges, including symptom distress, functional decline, and grief associated with diminished physical independence. These types of suffering are complex, and they require holistic team-based palliative care assessments and supports across physical, psychosocial, and spiritual domains, which together can help restore a sense of personhood, reframe hope and meaning, and mitigate desire to die in some cases. This is at the core of what we do in palliative care. In a 2018 systematic review meta-analysis of randomized control trials of existential interventions on spiritual, psychosocial, and physical well-being in adult patients with cancer, while the effect sizes on existential well-being, quality of life, hope, and self-efficacy were small, they were not inconsiderable. Indeed, the study authors concluded that their analysis provides evidence that adult patients with cancer across all stages and types benefit from existential interventions. And we know professors like Dr. Harvey Chochinov have spent decades researching these types of interventions. Furthermore, the editors of the special issue that this study was reported in also concluded that their analysis in the systematic review meta-analysis showed clear benefits arise from existentially oriented psychotherapy. So it's not that we have nothing to offer. Can we do better? Absolutely. But there are ways that we can help. If we look further at the Health Canada data, we can also see that 57.6% of the MAiD recipients reported inadequate pain control or concern of future pain, and the 46% that had inadequate control of symptoms other than pain or concern of future symptoms. This suggests a very poor level of palliative care provision overall. Even if it were the case that most of these cases were about concern of future pain or symptoms, such fears can be readily addressed by education on what palliative care supports can offer when and if needed. I'll refer you to a paper out today by Dr. Harvey Chochinov, who has got lots more details on the issues and assertions being presented in Canadian MAiD data. And it's in the Journal of Palliative Medicine. I tweeted about it earlier today. It's hashtagged with the McGill Palliative Care Conference as well, so you should be readily able to find it. Now I'd like to spend the rest of my time talking about the impacts of MAiD implementation on palliative care practice. In Carter versus Canada, the Supreme Court of Canada discussed what possible impacts implementing a law for assisted death prior to securing universal access to palliative care might have on the development of a strong palliative care system. Now we have over 6 years of lived experience, and we have seen significant deleterious effects of MAiD implementation on palliative care, including diversion of palliative care resources and increasing distress experienced by palliative care clinicians. Many Canadian Society of Palliative Care physician members have shared their first-hand concerns with us. I will go through some of those concerns. Some health authorities have incorporated MAiD into existing palliative and end-of-life care program rules. This has led to some palliative care nurses leaving their jobs because they're spending more and more of their time coordinating MAiD instead of being able to provide palliative care. In Alberta, British Columbia, and Ontario, some hospice palliative care nurse practitioners and physicians use their time in paid palliative care salaried roles to provide MAiD assessments and provision at the direction of their health system administrators. And please note that in some jurisdictions, there were no net new positions added after legalization of MAiD to account for this increased workload in MAiD that was put in their portfolio. So this is being done out of existing and limited palliative care resources, and in some places continues to be done that way today. In Ontario, doctors providing MAiD must use palliative care codes to capture and bill for their medical assistance in dying work at the direction of the Ministry of Health, despite strong advocacy against this from palliative care medical associations. Sadly, the use of these palliative care codes in this way makes MAiD providers eligible for a special premium meant to incentivize doctors to provide primary palliative care. Palliative care clinicians not involved in providing MAiD are finding themselves spending increasing amounts of time on matters related to MAiD, reducing their ability to provide palliative care. And there was a nice article by Dr. Jean Matthews and Camilla Zimmerman et al. That was published in 2021, summarizing some of these qualitative findings. In some palliative care programs, physicians are now being required to provide MAiD assessments as a condition of their employment. The Canadian Medical Association has clearly affirmed that a palliative care consult is not a MAiD assessment. And furthermore, MAiD assessments or provision are not part of the scope of practice of specialist palliative care, as discussed earlier. It is quite concerning that doctors would be required to perform an intervention that is not part of their specialized role. Certainly, individual palliative care physicians, like any physician in Canada or nurse practitioner, may choose to practice MAiD outside of their palliative care practice. But that should not be a requirement or condition of employment that they participate in MAiD. Any physician can choose to do MAiD assessments, but very few have the specialized expertise to address suffering in all its multi-dimensions through holistic palliative care. We have something unique and important to offer, and if our time is taken away from that, it's the patients who will suffer. A doctor providing increasing MAiD assessments has less time to do their traditional palliative care work. All palliative care programs in Canada are under-resourced and have more work than what we have the human resources to manage. We are decreasing access to specialized palliative care beds when health authorities require hospices and palliative care units to admit patients for the sole purposes of administering MAiD. And then, if we try to provide palliative care for these patients, as I discussed earlier, we can be accused of blocking access to MAiD. We're seeing increasing moral distress in palliative care clinicians from forced participation in MAiD due to some health authorities mandating MAiD be provided in hospice and palliative care units or lose their funding. This is resulting in retention difficulties and early retirements from palliative care, which is accentuating and accelerating the already critical shortage of specialist and generalist palliative care physicians. We also see patients unwilling to access palliative care services because they associate it with MAiD and are afraid palliative care will hasten their death or MAiD will be provided without their consent. We see patients accessing MAiD due to a lack of palliative care provision. And we see patients requesting MAiD because a trusted physician suggested it to them. I personally have met dozens of patients who have told me that they requested MAiD only because a trusted doctor told them they would be a good candidate, and they were scared that their symptoms would be very severe. UK palliative medicine consultant and Baroness Dr. Laura Finley told the parliamentary committee meeting last Tuesday studying MAiD that doctors have an inherent power differential in a consultation. Offering lethal drugs as therapeutic option gives the subliminal message that what lies ahead is so awful that you would be better off dead. Subconsciously, this may reflect unconscious bias or ignorance, shortcuts in care, or cost savings motives. And lastly, to finish off with some recommendations. I hope other countries can learn from our experiences in Canada. Implementation of MAiD legislation in Canada has significantly affected palliative care practice and is challenging the foundations of our discipline to be able to provide our good duty of care as palliative specialists, diminishing our limited palliative care resources, and further stigmatizing palliative care as a death service. The ongoing conflation of MAiD as part of palliative care with aggressive pushes from the margins to integrate MAiD within palliative care is an existential threat to our discipline and, in my opinion, is fracturing our ability to provide that duty of care we've talked about. Why is there an insistence that MAiD has to be part of palliative care when it can be readily provided and coordinated as a separate service, and those palliative care clinicians who also want to participate in MAiD practice can choose to do so? High-quality palliative care needs to be funded and universally accessible as an essential medical service, similar to maternity and emergency services, according to population needs. Currently, Canadians have a right to medically administered death, but not to medically administered assistance in living. Specialist palliative care teams should be funded completely separately from MAiD to ensure that palliative care and hospice resources are not eroded, as this would deny patients choice, leaving them the only option of death by MAiD. Hospice and palliative care units should never be required to admit patients specifically for MAiD to be administered, but should be able to maintain a focus on the relief of unrelieved causes of distress, whether physical symptoms or psychosocial or spiritual distress. We need targeted research and detailed data collection on suffering and MAiD, and the patient's voice must routinely be included in MAiD research and data monitoring. At this time, we simply don't have the adequate data, as I've said, to draw meaningful conclusions regarding access to palliative care at MAiD. We need to ensure that we continue to improve education about what palliative care is and all it has to offer for the 96% of Canadians who don't want to die by an administered death. The majority of undergraduate and postgraduate trainees get little palliative care education, but they all know about MAiD. MAiD must not become the default solution offered for any form of suffering. The Canadian Society of Palliative Care Physicians has consistently advocated for palliative care as a distinct and separate service from MAiD. We have never opposed MAiD. Canadians need access to palliative care to address their suffering and help them live fully with serious life-threatening illness. MAiD is a legally available life-ending intervention that some people will choose regardless of other options, but no person should feel compelled to choose MAiD because it is their only option or because palliative care or other needed medical and social supports have not been provided or are provided much too late to address their suffering. I will end with a quote from Dr. Balfour Mount. In his letter to the Supreme Court justices after the Carter decision, he said, "You need not be abandoned with unrelieved suffering. It's called palliative care. It should be offered to all Canadians because each of us matters, and we matter until the very end of our lives. You will not be left alone." Thank you.
Thank you, Dr. Herx, for this excellent summary, and also thank you for the energy and the time that you've dedicated to palliative care in general. And this is in addition, many of you may not know, Dr. Herx has 6 children, so really commendable. Next speaker is Dr. Downar, who's going to talk about the integration of MAiD within palliative care practice and implications for the future of our discipline. Dr. Downar.
Thanks. Good morning, everybody. Sorry, the wrong slides are up. You can just check, change those, that'd be great. I swear to you, Leonie and I did not coordinate our slides at the start, but if you want to put hers next to mine and put on some 3D glasses, they'll kind of come out at you. It'll be nice. I do have some disclosures. I've been the former co-chair of the Physician Advisory Committee for Dying with Dignity Canada. So naturally, I am now employed by a faith-based institution, go figure. And I've had consulting fees for educational material development, and I was an expert witness in Truchon Lam and the committees that Leonie mentioned as well. My objectives for today are fairly straightforward. I'm just hoping to get an appreciation that MAiD and palliative care are not actually alternatives and can coexist peacefully in a healthcare setting. To understand why so many people request MAiD despite receiving high-quality palliative care and avoid some common pitfalls when reading media stories. I want to talk about what I think is driving MAiD requests and provisions based on the studies and the data, to talk about some of the common myths and how we can move forward as a field. I really want to be super clear that everything I'm going to say here, any comments I'm going to make are directed at comments, not at people. I hope we all leave this room as friends. I also want to make it very clear that data does not answer a moral question. If you are morally opposed to MAiD for personal, religious, or whatever reason, it doesn't matter what the survey says. It also doesn't matter what the observational data says. If you're right even if 90% of the people are wrong. That said, the moral objection cannot retroengineer, data, right? Like we can't sort of, pretend that the data isn't there because we have a moral objection. So again, I do want to emphasize that I think what drives MAiD request is generally physical symptoms, anxiety, not physical symptoms, I should say, anxiety really, or depression. It is mostly existential distress, which is hard to define. One recent study of 63 papers found 56 definitions of existential distress, so we're narrowing it down. And I think it is important to recognize the limitations of what we can do for this type of distress, or anyone can. It is not extremely well studied, but what data out there is far from impressive. Again, Leonie's already showed you the slide, so I don't have to. I think the question, though, of whether MAiD is caused by what I'll call palliative care deficiency syndrome is I think one that I think we can answer quite conclusively. Based on objective data that we have, and I'll show you more, I think it is impossible to sustain this narrative. We can say that based on individual cases. We can say that based on studies of populations known to get more and better palliative care. We know about regions with good and bad palliative care. We know about opioid availability. You've seen this slide already. Again, in the subjective judgment, I completely agree, the subjective judgment of people in the Health Canada studies would say that something like 2% or less of people who received MAiD did not have access to palliative care and did not receive it. Everybody else either got it or had access to it were they to have needed it. I think the duration of palliative care before they died, understanding that these people did not have a natural death, if you span it out to what you would expect palliative care to be provided for people in our population, this is actually a fairly early palliative care population. But it's important to state that that is not the only source of data that we have on who is getting palliative care. There's more. So you saw this, you heard this study referenced, which was the study that I did with some colleagues based on a deep dive through data collected by the Office of the Chief Coroner of Ontario. So let's be clear on where that data comes from. That data is derived on chart abstractions performed by nurse investigators working for the Office of the Chief Coroner of Ontario, right? Now, we can argue till we're blue in the face about quality and who actually is a real palliative care doctor or not a real palliative care doctor. You will not find an unbiased person in the world. That I don't think exists. Everybody has an opinion and everybody will have some tilt. But these are people who are hired. All they do is look at charts and assess quality of care and type of care delivered. That's all they do. And these are the people, this is their judgment. I just can't think of a less biased person. And the assessments that they came up with based on their assessments and understanding of who's registered as providing what type of care in the college and looking through charts was a number that came remarkably close, within a couple of % of these subjective self-reports of Health Canada. To me, that suggests that I think people are probably doing a pretty good job of reporting what's actually being provided to patients and not just giving the sort of socially desirable answer. It's also important, there's a number of different demographic findings from that study that we need to recognize, that the patients who are getting MAiD are actually remarkably privileged people as a rule. So you're seeing much, much higher probability of coming from high-income quintiles, a dramatically lower likelihood of coming from an institution than people who, general members of the population who die. Much more likely to be married, less likely to be widowed, right? So loneliness, institutionalization, the things that people worry about really do not seem to be substantial drivers of this to any degree. And again, this has been shown in other studies that these signals are durable. Again, even if, okay, so let's say you're concerned. These are biased assessors. You're not sure that you really can trust the assessment of a nurse investigator working for the coroner's office. Okay, I'll play with that for a moment. I think it's also important to recognize that there actually are no objective measures of quality and absolutely no measures whatsoever objective of access. So it is always a subjective judgment. One cannot prove either way. Any arguments made on what access is or what access isn't are hand-waving arguments. I know what you got and I know what you didn't get, but what you had access to if you didn't get it, I don't know. I can't prove it anyway, I should say. We know that Canadians, certainly Ontarians, are receiving care from somebody who is a palliative care provider or does mostly palliative care about a little over 50% of the time. It's a number that should be much higher. But the people in our cohort, the people who get MAiD, are doing far better, far, far greater involvement of palliative care than any subpopulation you might care to mention. And if there's a concern that is really about quality and timeliness, so theoretically there's this pile of people who must be getting very good early palliative care, and they're getting no MAiD, and then there's a group of people who get late or poor quality palliative care. Well, there's also a third group of people who get no palliative care at all. Why would all the MAiD happen in the middle group? If this was actually something related to palliative care quality and access, you really should see a lot or more MAiD in the group that gets no palliative care at all, and you don't see that at all. Access, quality are serious problems in Canada, but they are not the problems driving MAiD. A thought experiment for you. Let's take some populations that we do know something about. Cancer and end-stage organ failure. So let's, if I have somebody with lung cancer and somebody with COPD with approximately 3 months left to live, who has the higher burden of suffering? Lung cancer or COPD? Shout it out. It's actually COPD, yeah. It depends on which study you believe, but certainly lung cancer is no worse than COPD. And of course, who's more likely of these two patients to get home palliative care? Cancer. Who gets early palliative care? Who sees palliative care more frequently? Right. Who gets, again, you see all the numbers here. Twice as likely to get palliative care, 4 times as likely to get palliative care in the community. You get it 3.5 months from your death for the first time instead of 3 weeks from your death. Who gets more MAiD? 3 times. 3 times more commonly, the cancer patient gets MAiD. 8 times more commonly, the cardiovascular disease patient gets MAiD than equivalent cancer patients. There are very powerful drivers of MAiD, and palliative care is not one of them. Okay, it is impossible to sustain that narrative based on simple observation, and there's nothing subjective about this data. This isn't based on assessors. This isn't based on anything. Okay, just simple things that we know from observational data. I'll skip over opioid availability because I don't think it really was as relevant to Canada. It's also important to recognize that the existence of MAiD or the presence of MAiD in groups that one might consider vulnerable or low income is not proof that those were driving factors, right? You actually have to look at comparator groups and look across a whole population. So for example, let's take income, and you have quintiles of income. If income was in no way responsible for driving MAiD, you would expect to see roughly the same incidence of MAiD in all of the various quintiles of income. It should be the same. If income was a driver, right? So if poorer people were more likely to have unmet symptoms and were driven to MAiD, you would see higher provision of MAiD in the lower income quintiles than the upper quintiles. You see the opposite. Okay, so arguably lack of education, institutionalization, lack of access, socioeconomic vulnerability, social deprivation are statistically protective against MAiD. Which raises other questions about access, but I'm not going to get into those today. And I think we also have to be a little bit careful when we talk about things like self-reported data, which I totally agree. You have to be very careful when you interpret self-reported data. But we also have to be careful to be consistent with our logic, right? Like we can't sort of say, well, I don't trust the self-reported data, and did you see this story on Twitter? We have to be consistent, right? Like if we're going to be skeptical of self-reported data, understanding that everyone is kind of biased and it's a very hyperpolarized political environment, we kind of have to be skeptical of everything. Okay, I don't wish to cause an existential crisis in this room, but I also think that things need to be said. The notion that really I think we have to improve access, availability, services, support for palliative care across the board, but not because it has anything to do with MAiD, because it's the right thing to do, because there are a lot of people who don't have access and there are gaps in quality. But the notion that if we were to do this, and this would have a dramatic impact on provision of MAiD and relief of suffering, that's an assumption we have to be a little bit questioning of. So remembering that statistically, palliative care actually does improve outcomes, and I think we have data for that. But our effect size is actually a lot smaller than sometimes we lead others to believe. Okay, so here you see on the left panel, this is David Currow and the symptom report by family members in the final 2 weeks of life based on whether they received palliative care or no palliative care. Now, obviously, it is statistically the patients who received palliative care did better than those who did not, but almost 50% of those who died receiving home palliative care in a very well-resourced and well-run palliative care system, palliative care service in Australia, almost 50% were somewhat or very uncomfortable despite receiving that. And I work in the best palliative care unit in the world, by the way, so if I ever have to die, I want to be in my unit. But if there wasn't a bed available, I just might be convinced to accept a bed at the MD Anderson palliative care unit in Houston. And this is what happens in the final week of life in that facility, right? So you see here, this is proportion of patients who have symptom scores of 4 or greater, so moderate to severe symptoms, in the final week of life while admitted to the acute palliative care unit at MD Anderson. You'll see that, you see pain scores of 4 or greater in about 30–40%. Dyspnea scores up to 70%, 60–70% are having moderate to severe dyspnea despite being in palliative care. And staying with MD Anderson for a second, looking at the effect size of what we do. So those not familiar with standardized mean differences, these are sort of a way of standardizing the magnitude of an effect of an intervention. So this is a recent paper by Dave Huey and Eduardo looking at pooled meta-analysis, systematic reviews of the effectiveness and the effect magnitude of palliative care interventions on quality of life. So those not familiar with SMDs. An SMD of about 0.8 or greater would be considered a large effect. 0.5 is a moderate effect. 0.2 would be considered small, and 0.1 is insignificant or no effect. Quality of life, we're about 0.2. So we have a small effect pooled. This is meta-analysis. This is specialized, multidisciplinary, specialized palliative care in a studied environment, right, ideal environment. And this is how well we do. For symptoms, our scores, our improvement, our effect size is somewhere between 0.1 and 0.2. For mood, nothing for existential. We didn't obviously have that here, but I don't want to use mood as a surrogate. But for mood, we're actually not even measurably effective, right? So our effect sizes range between ineffective and small for all of the things that we say we're supposed to do. Access is not the only gap we have to close. I'll repeat that. Access is far from the only gap we have to close. And implying that simply us being more ubiquitously available would make all of these MAiD requests go away, I think is not intellectually honest. I think I do a pretty good job. I try. I think a lot of my colleagues do a pretty good job. But I can't go to society and say, we've got you covered with data like this. We just can't. I want to address some of the common comments here about, do patients avoid palliative care units and hospices where MAiD is, or where MAiD is allowed, I should say. That was wrongly put. I have trouble sometimes with this story because, what you're having a situation where someone will say, oh, I'm not sure if I want to go to a palliative care unit. And you say, well, what are you worried about? Well, I'm worried I might get MAiD when, that I don't want. So, well, you can't get MAiD that you don't want. That's against the law. And they'll say, well, I don't trust the law. So, well, okay, this hospice has a policy. Oh, okay, in that case, I'll go. Like, I don't, the concept of a person who is not reassured by like criminal code provisions that might land this doctor in jail, but is reassured by a policy. I've never met that person. And I don't really think that person exists. I just don't think that's a very logical explanation. And often 9 times out of 10, these conversations are happening in acute care hospitals where MAiD is legal. So clearly this person doesn't have a serious problem being in a bed where MAiD is allowed. I struggle with this one. Do MAiD requesters create excess demand on palliative care? I don't really think that they do, because most of these patients, as we know, are already followed by palliative care. These patients are generally known to the service. There are obviously referrals that come to us as sort of like, oh, this person's suffering, this person's asking for MAiD, could you come? You kind of drop everything, go and see the person. This person's dying, and this person's suffering. That's kind of my job, right, to see this person. I don't know that, the fact that whether MAiD was or wasn't legal or whether a MAiD program did or didn't exist, I should probably see this person, right? Like that's has nothing to do with the legality of MAiD. I take the point that sometimes MAiD services are foisted, like administrative services are foisted on administrators because it's a 0.2 FTE, and so, this happens. But the challenge I have with this, of course, is the concept that these resources belong to me or you. They don't. They belong to patients, right? So if someone is dying, coming at or near the end of their life, and has terrible suffering so bad that they want to end their life, I struggle to see why is it inappropriate that those people get resources from a palliative care service? That I struggle with, because it's not sort of like this is MAiD and this is palliative care. This is patient care, right? And I just struggle with that logic a little bit. I certainly take the point, and I completely agree with Leonie, that no physician, no member of a palliative care team should ever be forced to perform a MAiD assessment or a MAiD provision. I'm quite surprised to hear that story. There's actually explicit provisions in the law and every policy of every college across the country that should not be happening. That's wrong. I would also point out, though, that there are a number of incidents where young palliative care physicians being hired on were forced to sign contracts that they would not provide MAiD as a term of their employment. Others have been told that their salaries would be reduced if they provided MAiD, and others were told verbally that they would only be hired on the condition that they did not join the local MAiD team. Again, anecdotes. I'm not going to write down. I'm not going to write down names. I'm not going to tell you who they are, but I think that this has to work both ways, right? I think it's really important to understand that I fully support people who oppose MAiD due to moral personal beliefs. I have so many friends who really disagree with me on this point. My entire family are Catholic, I swear. Yeah, it's kind of bad. But the issue of, I have 2 evangelical Christians in my division. I love them both. I am actively recruiting an Opus Dei Catholic. We are all welcome. We should be all welcome in palliative care. I really strongly encourage people not to push these sort of pejorative narratives that MAiD is being driven by the government. So one thing missing from the historical timeline from these legislative bullets was actually what caused all of them. None of these were government acts. These were all forced on the government by patients, people with disabilities who went to court and fought for their rights. And the government, kicking and screaming, fought them tooth and nail all the way. And this is my story because I was in some of those court cases. And let me tell you, I can't put into words how it makes me feel. When I went to court, I worked completely pro bono. My fee was 1 poutine, I swear to God, it actually was a poutine. I paid for everything myself. I go to court at the request of a person with disability and file an expert witness. The government brings my taxpayer dollars to bear against the person with disability who's fighting for their rights and hires any number of experts you can name, all of whom took my money, my tax money. And now those same experts are writing notes and Twitter notes saying that the government is pushing this on disabled people. I can't tell you how that feels, but it doesn't feel good to read stuff like that because it's not true. The notion that this is driven by vulnerability or naive patients who are sort of uninformed and unaware of their options, that lack of palliative care we talked about. The more pejorative narratives about unscrupulous or elitist, ableist providers, an option taken to save time and money. I pray every day I walk into the rooms of my patients, I say, please, please, please don't request MAiD. Because if you request MAiD, that's my afternoon gone. I am going to be buried in so much paperwork. This is such a long process to go through. It is so burdensome. And people quit just due to the administrative burden and the stress of having to go through this. Anyone who thinks MAiD is an easy option knows nothing about MAiD. It isn't an easy option. It's a crap ton of work, and people quit because of how much work it is. And also just remember that conscience rights, and I'm a very firm believer in conscience rights, but remember that all sides of a debate are entitled to conscience rights. If you only believe in conscience rights for half of a debate or one side of a debate, you don't believe in conscience rights. Valuing human life, I'm sorry, I'm going to go over a little bit because I think I just want to finish off some points. I'm reading about also horrible things read about how Canada basically eats babies. I think it's important to challenge that one head on. You know, this isn't about a culture of death or elitism or ableism. It's about a culture of choice. If you want to know how Canada feels about our disabled people and how much we value human life, it's probably better to look at, say, for example, a global pandemic where lots of people die, particularly people with, in vulnerable states, and people whose lives could be protected by, public sacrifices or people stepping up and wearing masks and getting vaccines and generally staying at home and doing boring things rather than going out and having fun. And on that regard, Canada does pretty darn well, actually. We actually saved a crap ton of people. We did pretty much better than every high-income country that wasn't surrounded by 300 miles of ocean. And I think we actually have rightly to be proud of that. Like, that was a decision that we made to sacrifice, and it was a sacrifice. It was fucking hard. And we saved a lot of people, and they're still alive, and we're struggling right now. Our system is struggling. People are leaving healthcare. They're burned out. We're losing healthcare workers far more than we lost patients. And if other countries are doing better than us, it's maybe because they lost a lot of patients, right? And we're still struggling to keep these people alive. That's what we think about human life. And I will also say this, and again, this is not directed at any individual, but just maybe just a quick reminder that there are a lot of things we know about what saves lives, particularly among the vulnerable. There are things like social assistance and pharmacare and dental care and firearm restrictions and COVID vaccinations and COVID vaccine mandates and mask mandates. We have a lot of data showing how many lives these things save. So when I appear in front of a parliamentary committee and somebody from a politician who is opposed to literally every one of these things, who brings coffee and Timbits to protesters who take over my town, in the aim of bringing down every one of these things, knowing full well that that will result in large numbers of deaths of vulnerable people, starts to lecture me on the value of life and ableism. I don't like that very much. And I will tell them about it. And I would strongly encourage anybody who feels that they want to protect the lives of the vulnerable and help the vulnerable. I really hope that for every one tweet you send about MAiD laws, that you send 50 to 100 tweets and messages about things that actually really profoundly affect survival in this population. And when you line up in a political environment, please look around you, because if you're lining up with people who are against this stuff, you're on the wrong side. Understand what's driving MAiD and what's not driving MAiD. Accept that palliative care interventions have a limited effectiveness. This is not a sign of our failure, but an encouragement for us to continue our research and push hard to do better. Please don't put up barriers for patients and colleagues. Everyone, we need to all work together. The purpose of palliative care is not to prevent MAiD, and MAiD is not a failure of palliative care or healthcare in general. And let's try to be scientific and data-driven. I'll stop there. Thank you.
Thank you very much, Dr. Downar, for your excellent expose. Now, back to the beginning. So we'll invite my colleague, Dr. Tradounsky. Back to the beginning. Here we are in the field. We're on a consultation service, and we have a patient in front of us who's suffering. Questions like, what do we say or not say about MAiD? How do we teach it now? What about challenges like, I have a patient who wants to keep his choice of MAiD a secret from his family, and we know legally that that's allowed. How about my own personal wishes regarding my life maybe not being the same as my professional views? How about that? So to address these very practical thoughts and questions, we've invited Dr. Tradounsky to talk about her experience day-to-day as a clinician, as a teacher. Dr. Tradounsky.
Okay, Anna, that's not fair. You didn't tell me you wanted me to talk about all these things. So when Anna asked me to talk and bring my own perspective, I accepted. And so this will be a much more personal, and it's also more Quebec-centric because this is where I work. Oh, I guess I can take my mask off. That's true. And then when I wrote a bunch of notes after speaking with Anna back in March, it seems, and I decided I'm not going to prepare. I'm just going to talk straight from my heart. And then last night when I was reading my notes, I was like, oh my God, I could probably speak for an hour, and I only have 15 minutes, so I'm going to be reading what I wrote last night. So I'm sorry about that. First of all, I would just like to say that I have been receiving little forms of payment from Palliative for teaching palliative care. But otherwise, today I just want to explore what some of the palliative care physicians have been, thinking about and going through. So personal perspectives as a physician, also the notion of, with the legalization, how we change, we evolve, our thinking, our feelings, etc., and a little bit of what the future holds as well. So I'd just like to start by saying I am a family physician, and I've been practicing palliative care for 24 years, and exclusively for the last 19 years. I also had a role of program director at McGill for 7 years, from 2007 to 2014, and again, just before the pandemic hit back in November 2019. So I am responsible for the undergraduate and postgraduate teaching. I work in a small community hospital. There are a total of 9 physicians in our hospital who work there daytime, and 3 physicians who work on the palliative care unit and in home care, and all 3 palliative care physicians have had extra training in palliative care. So I went into palliative care for a variety of reasons, and I won't go through that now, but the aim was mostly to make sure that this very important part of a patient's and their family's life was accompanied, supported with caring, sensitivity, and basically the dominant message was the notion of quality of life. Initially, when the Select Committee on Dying with Dignity started touring Quebec in 2009, interviewing stakeholders about the importance of dignity at end of life and how people wanted to die, I welcomed this open discussion on death and dying. It'd been a taboo subject before. People were scared of coming to palliative care, thinking that palliative care equated with dying. And so I'm thinking, oh, okay, good, we're going to start talking about this. However, my feelings quickly turned sour. Why could people die with dignity only by euthanasia? I'd been accompanying people in the last chapter of their life without providing euthanasia, and they, in my eyes, were all with dignity until their death. And the Select Committee was going around interviewing people, patients, physicians, religious figures, etc. But they never defined what palliative care was, the ethics of withholding or withdrawing treatment, the ethics of palliative sedation. And honestly, there was a lot of confusion amongst lay people, but also the medical and nursing staff about what all of these different kinds of treatments were about. So I started realizing that people were not necessarily talking about euthanasia when they were clamoring that they wanted to have death with dignity or medical aid in dying. I was worried that people were not being educated about palliative care, that they were scared of palliative care, and not just the patients, but their doctors as well. I've had one family tell me that they had requested palliative care for their mom, and their oncologist said, oh, no, not yet. She's not ready for that. So it was actually sometimes even the doctors who were preventing people from accessing palliative care. A large proportion of patients with serious illness were never getting any form of palliation. And the stats were showing that only 30% of people in Canada and Quebec had access to expert palliative care. I was concerned that insufficient palliative care access meant that really people had very little choice. So if they couldn't get relief from their physical symptoms, they could decide to leave with unrelieved suffering, or they could opt for euthanasia. And to me, this didn't seem to be much of a choice. So actually, many years ago, I don't know if it was 2009 or a few years after that, I went to speak in front of the committee along with palliative care colleagues who were all opposed to the legalization of euthanasia, and I had had a personal experience with dying. My father died at a young age from lymphoma. A few months before his death, he mentioned to me he would commit suicide if things got really bad. And I was 21 at the time when he said this to me. I was shocked to hear him say this. As time went by and things got from bad to worse in all kinds of ways, his strong spirit took over. And he told me, if I can't windsurf anymore, then I'll go on the catamaran. And that was maybe a few weeks before he died. Many years later, when I became a doctor and a palliative care doctor, I knew that this difficult period in a patient's life is one where there can still be coping with lots of loss, growth, and teaching. I know that patients are always teaching us all kinds of life lessons, and that this is also an important time for families to be able to prepare. I also told myself that I would never do euthanasia, and that if I ever was forced to, I would prefer to hang up my stethoscope. I have heard that some doctors have done some atrocities during the Holocaust, and that they probably convinced themselves that they were doing things in the name of advancing science, helping mankind. If they were able to convince themselves of such things, I can't say that I'm immune to being swayed, and I wouldn't want this for myself. So my values and respect for life are personal, not from a religious background, but I wanted and still want to hold on to those values. I guess I forgot to switch slides somewhere along the way. So anyway, CanMeds, here we go. My initial perspectives, and now we've got legalization. All right, I could have not done with the slides, but anyway. So the law came into effect in Quebec in December 2015. And it was the law concerning end of life. It had three parts to it: advanced medical directives, palliative care and palliative sedation, and medical aid in dying. And I truly disliked this euphemism for euthanasia. People were being fooled with a softer name. I was also furious that this MAiD was being enforced throughout the province, but that quality palliative care was not. And I was, I had been training young physicians, and I knew that, throughout the four medical faculties in Quebec, there were so few palliative care trained physicians going through, and that those physicians were having so many hoops to jump through to be able to get to work in palliative care, and still now. So palliative care expertise, not that much throughout the province of Quebec. In 2015, they also promised money was going to be given to our community health hubs, which are called CLSCs, and that would be to increase palliative home care. But there was absolutely no supervision to see where this money was really being spent. And I know that CLSCs are always scrambling for finances towards the end of their financial period. And basically, they got this money that was meant for home care, but we're not sure that it ever actually went for palliative home care. The government also put together some teachings for nurses and orderlies, and they were expecting all these different facilities, hospitals, etc., to offer the teachings, but the government never offered any kind of compensation for this teaching to be done. And so we were expecting people to come on their time off, on their vacation days, to get the teachings. I mean, we had to find ways of getting this teaching to be done, and it was all basically pulling very tightly on resources. So they also organized presentations in various areas of the province to educate healthcare professionals about MAiD. In my region, I went because I thought, I tend to see a lot of people at end of life, so I should know what this MAiD law is about. And I saw mostly palliative care physicians attending. Where were the oncologists, the internists, the neurologists? I guess I didn't feel concerned. Did they think that MAiD was only the business of palliative care physicians? I didn't feel that it was. The government had promised there would be leaflets to educate patients about the law, and I mean, there are three parts to the law. And so they would know about this law and their rights, but this never materialized. We still haven't seen any educational leaflets anywhere. And now, how ironic that my palliative care colleagues and I had to inform our patients about the legalization of euthanasia and advocate for them when they were requesting it. And then there were the first requests. I was sure that when a patient of mine would get MAiD, I would probably not be able to sleep afterwards. And I surprised myself that I did sleep. I had done a good job with treating all the physical symptoms. My patient was comfortable. She didn't have any anxiety or depression. She was actually enjoying her time with her family, but she wanted MAiD. So I had nothing to reproach myself. She received MAiD, and as she wanted this, because basically this was a question of being able to control this part of her life, and she had always controlled things in her life. And I guess we can put this under, the name existential distress. There was not much I could do about this, and I have to wonder if maybe more spiritual care workers, psychologists could make a difference. Maybe, not sure. But this is what the reality that my colleagues and I have witnessed, and also reflected in the statistics from the federal government, and Leonie showed us, that the great majority of the MAiD requests are driven by fear of future suffering and existential distress. Those types of suffering are difficult to address, even by the best-intentioned interdisciplinary teams, and the teams are not always staffed appropriately. We just got our first non-denominational spiritual care worker in the last 6 months. And I've been working for 24 years at Mount Sinai Hospital. And it's in the last 6 months that I finally got a wonderful addition to our team. Psychology, haven't seen him since the beginning of the pandemic. So these are not necessarily well-financed human resources in our hospital systems, and how can we address these difficult sufferings that our patients are having without the proper teams, and never mind in home care. Those psychologists, spiritual care workers, for sure, will be missing for the majority of teams. What had initially been presented by our government as a care, which would be infrequent and exceptional, became a frequent request. And surprisingly, the government, the Ministry of Health, turned around and came and asked the administrators of my regional health service, why are we not providing as much medical aid in dying as other areas of Quebec? So now they were actually pushing for us to do more. And then the question is there some kind of conflict of interest? The Canadian government admitted that last year, in 2021, $90 million were saved thanks to having medical aid in dying. We've worked very well with the providers of MAiD who evaluate these patients, and some of them get to see our patients before we ever get to meet them, because sometimes the request is sent to them before the request is sent to palliative care. So they actually educate these people about the option of palliative care and palliative sedation. And my colleagues and I are super grateful to them to have volunteered to do this. But as expressed maybe a bit earlier, a lot of these evaluations to see if patients fulfill the criteria for MAiD, they're very subjective. Like, how much suffering is intolerable? What is severe debilitation? What's foreseeable death? Is it a question of months or years? And now we know that that's been removed from the law. But back in 2015, up until this past summer, this was a question that I had. How much delirium does there need to be to make a patient inapt to consent to care? Because we know that patients need to have full aptitude when they are being assessed initially. As a physician and advocate for my patients, but also a conscientious objector, I've had the bizarre conundrum of needing to request access to MAiD for some of my patients when this request had fallen upon deaf ears earlier, when other doctors didn't want to have to deal with this. But also in my evaluations of their suffering and asking them to wait and see if a particular treatment could be of help for their suffering, was I being an obstacle to their right to obtain MAiD? And so that was part of my questioning, and I was feeling really very torn. As a teacher and program director, I've needed to educate future physicians about the rights of our patients, but also the nuances. I've not necessarily been unbiased, as I've pointed out, where government has not done right by the population, not enough education of the population about palliative care, advanced care planning, the differences between MAiD and, what I was pointing out earlier. And a lot of people have said, oh my God, we didn't know that these resources, these home care resources were available until we actually really needed them, and sometimes, unfortunately, got them a bit late. Also, there's a huge lack of any kind of palliative care expertise in nurses and physicians, so that when we talk about the palliative care approach, we still have a long way to go. I have a reminder I'm supposed to switch slides. That was part of my writing last night. So, where do I stand? I've never actually been categorically against the legalization of euthanasia. I don't know how I'm going to react when I'm faced with a serious illness or an imminent death. However, I would have wished for a more robust palliative care presence everywhere across Quebec and Canada before MAiD was made into law. We've quickly witnessed the dreaded slippery slope where people just need to be handicapped without being with any terminal illness to get access to MAiD in Canada. And this will probably be coming to Quebec very soon. Where a foreseeable death clause was removed altogether, which is ironic because the Quebec law is still entitled the law concerning end of life. But anyway, where having capacity is not necessary when you're about to receive MAiD, as long as you had capacity when you were assessed. Where soon mental health illness and babies will be allowed to get this procedure. I am grateful that the Quebec government has actually said that, being tired of life is not a reason to access medical aid in dying, which is happening in European countries. So anyway, and the kind of person I am, I try to stay somewhat optimistic. There's the Quebec Action Plan 2020-2025 for access to palliative care, which came out only this summer, so maybe 2 years late, which outlines some ways of ensuring better palliative care access by improving education of the population of healthcare providers about the law and improving palliative care capacity, dedicated money, et cetera, et cetera. So, I'm hoping that there will be much more palliative care available to the population. Palliative care is one of the options at end of life. MAiD is another one. I'm going to remain a patient advocate. I will not abandon my patients. I will continue to provide the best care possible. I don't want to abdicate my values. There's been a compromise and adaptation to new realities, including what to teach students and residents. I have added an actual teaching, a core teaching, where one of the MAiD providers teaches my palliative care residents about what MAiD is. And we do usually have a chance to talk with the medical students when they come and spend a few weeks with us, so they are better informed about medical aid in dying as well as palliative care. And I have to say that my feelings have changed. Whereas in the past I was furious, I now have serious concerns about the future for our society. A society that doesn't value enough the lives of people with handicaps, terminal illnesses, and mental health issues to put the resources in place to help maintain these people's dignity throughout their life course. So I'm going to stop here.
Thank you very much. Thank you very much, Golda. So you see feelings, personal forms of and shades of moral distress, and for every one of us in the field, the sources of this distress and these feelings might be different. Originally, I asked for a day-long seminar, but there you go. What I'm hoping is that in your own centers, you will allow room for the research to be reviewed, for research to happen, and for these feelings and manifestations of moral distress to be aired and discussed. So now we go to the comment and question period. And again, I would ask you, it's not too late to engage in the e-event. I have we have to privilege responses from the panel here. I have a request from Dr. Herx. Dr. Herx, did you want to comment? Do you want to come up to the podium if you do, or yes, you've got a mic.
Are these on? Okay, sorry. If it's okay, I just want to make a couple of comments. I agree with James that we really need to look at the data, but we have to ask the right questions and do the right research. And as I mentioned, I don't think we've done that. And I appreciate what you have to say, James, but I wonder if people read the articles, like the one you mentioned about Kuro, for example, it's the symptoms in the last 7 days of life. And so many of those symptoms that they were evaluating, for example, would just be normal symptoms that happen with dying. And so it's not really to say that palliative care didn't do anything. That's just actually what happens when you die. You get more tired, you sleep more, like the things they were measuring. So I don't think that's necessarily fair to say that palliative care didn't have any effect.
Can I clarify? So on that slide, I was very careful to say that I don't think that did say that. Right? Like it was the comparison on the next slide where we talk about what effect in very controlled scientific settings we do have. Like, what is the magnitude of what we can do? I'm sorry, we could talk more.
No, I know. We're not here.
But I'm really no. I get it. Like, palliative care is not useless. James Downar, 2022, palliative care is not useless. You heard it here first.
I just want to clarify one thing, that nowhere have we ever said that lack of palliative care is driving MAiD requests. We are saying that we don't know because we don't have the right data, and that there is an issue with access to palliative care, and 96% of people in Canada are not choosing MAiD, so we have to do better to improve both the quality and access to palliative care. And I disagree that the patient owns the resources. I think, unfortunately, the way healthcare is funded, if there's a limited budget, right? So if you're taking existing palliative care resources that are already underfunded to promote a new service, you are reducing palliative care resources. That's just a fact. Thanks.
Thank you. Any other comments from the panel before we go to the long list of comments that I have here? So this, I don't know, this might be for Dr. Herx. Is there a plan to resurvey the Canadian palliative care physicians on this topic to get a sense where the Canadian Society of Palliative Care Physicians are feeling now, 7 years after legalization?
So do you want me to answer that question? Ebru's here. She's the current president.
Oh.
Would it be okay to invite her up? Or?
Yes.
Okay. Yeah.
Take whatever
This
mic
is Dr.
is.
Ebru Kaya. She's the Canadian Society of Palliative Care Physicians president. I'll just ask her to answer.
Sure. Go ahead.
Sorry,
Find a
my
mic.
voice is really squeaky, which is why I've come up. Not that I want to take away from our three amazing speakers, but just to say that we've definitely discussed it in the board and we're considering it. And I'll definitely take it back at our next board meeting again.
Can I make a suggestion also just from our side? Like, I don't know what a poll, a survey would actually add at this point. More, I think it's fair to say that there's a substantial proportion of the palliative care community that feels in any group on this issue. And I don't know that, like, for sure we're going to see some changes from the previous, and then a lot of tea leaves reading over what that means and whether the sample was random or not. At the end of the day, does that answer a question that we need to know the answer to? I mean, we all know that in every division across the country, there is a substantial proportion or some proportion of the group that is involved in MAiD and is involved in MAiD assessment and provision, and also a substantial proportion that want nothing to do with it at all.
This is I don't know if this is a question or a comment for any of you. How is the community being educated regarding palliative care? What is palliative care and what is MAiD?
So in Montreal, we have the wonderful Council on Palliative Care that does a lot of outreach. But honestly, I have not seen much with respect to, I mean, I watch TV a bit. I haven't seen any ads on TV from the government about law number 2. With respect to, like I said, it has 3 parts. You might as well teach about all 3 parts. They're important. There were supposed to be flyers, educational flyers. Anna, you work in a large tertiary care hospital. Have you seen any flyers around?
No, I haven't.
And I haven't either. So there is not much unless people probably start Googling. And then even then, I kind of don't always find that the ministry's health information is all that clear. But there is stuff on the internet for patients to go and educate themselves should they wish. I still am telling patients now that euthanasia, medical aid in dying, is legal. They don't even know that it's legal still. So I'm in a weird position, like I said, where my goal is to have quality of life for these people until their last breath, and I'm still having to teach people about euthanasia being a part of the law.
Can I add? A lot of people don't even know what palliative care is, right? They just think it's giving high doses of opioids at the end of life and shortening people's lives. Like, I still have patients I see in my clinic who think that, and I still have patients who think that when they're asking for medical assistance and dying, they're asking for comfort while they're at the end of their life, which is palliative care. So we need a huge public education campaign on palliative care as well, not just what euthanasia is.
So a message to all of us, a message to self. In these forums, we should invite policymakers and people from the Minister of Health. A question for all of us here, I think. Has the introduction of MAiD changed the dynamics and relationships between healthcare providers who provide it and those who don't in the institution you work in? And if yes, if MAiD has changed these dynamics, how is this being dealt with?
Well, we need a whole session on that.
There we
It's
go.
very complicated, and I think each culture is different. Yeah.
Here's another item. Does dignity have an accepted definition? And do you agree with it, or do you think it has nuances that are difficult to define? There's another day, right?
Can I dive on that one and avoid the first one? No.
Go ahead.
The first question is, I mean, in my division, I very unscientific poll. 34 sort of full member, 38 including locums. Of those, I can count probably 13 that I know are involved in MAiD provision or assessment, and probably I would say a half dozen who are pretty opinionated opponents and highly respected members of the group. And I would say that occasionally we have the moments where it's like people get frustrated with one another around a comment made or something like that. And sometimes when we're not, when we didn't eat our Wheaties or somebody gave us decaf by accident, it goes, so, but I wouldn't say, I don't really think it comes up very often in my group as a big issue. The question of dignity is one that I think ultimately, like everything else, is a question for every human, right? Like, I mean, and again, I like when you live in a world that ours lives in, like we are in very much an autonomy-focused world now, for better and for worse. The bar to criminalize things in Canada and in many other countries is just rising higher and higher and higher, right? And it's not that we necessarily like what people do as a result of their autonomy, but we just feel that it is ultimately up to them and should be up to them what they define that as. And so I would say I don't think I would want to hazard a universal definition of dignity.
I'm just going to jump in on the first question, if that's okay. Sorry, I know you're ready to move on, but I heard the question as something outside of our palliative care programs and more like at the hospital level. Both are probably important. And I think it depends on where you work, but there are, as I mentioned earlier, a lot of hospital policies that are being set that are, and I agree it's wrong, mandating physicians participate, and not just physicians, clinicians' participation and facilitation in the MAiD process, because there's not enough people doing MAiD. So I've heard of hospitals where they're considering that as a privileging requirement, that you have to agree to do MAiD assessments. And it puts a lot of distress and moral distress on physicians. And it is causing division within teams in the hospital. And then there's also this understanding, because palliative care said we don't own MAiD. When it first came out, it was like, end of life care, reasonably foreseeable death. As Golda said, it was kind of expected we were going to do it and lead it. And because we said, wait a minute, that's actually not what palliative care does. We're distinct and people can have access to MAiD and get palliative care. They saw that as opposing MAiD, which I made a clear point to say, yes, BCP doesn't oppose MAiD. But it's still being interpreted. So we have institutions and people have told us that some of their MAiD providers don't want to involve palliative care because they see us trying to talk patients out of getting MAiD, which is absolutely not the case. And you heard Jose Pereira testify to that at the committee earlier. So there's just dynamics happening that are making it very distressing environment to work in healthcare when we're already distressed with under resources in palliative care.
Can I just jump in on the one? If there is anyone in the room who at any point is told by your hospital as any condition of anything that you must participate as an assessor, even as an assessor of MAiD, that is completely illegal. That is written in Bill C-14 as contrary to the law. Every college, regulatory college, makes it clear that there is no obligation to participate as an assessor or provider of MAiD. Just write down a very large number on a piece of paper and tell them that's how much money you want to keep silent.
We have room for one more. I think this is more of a comment than a question. Other procedures such as endoscopy or active chemo are not within the scope of palliative care. So are you suggesting all procedures be included in palliative care because it's, in quotes, good care? General comment. So,
including MAiD in palliative care because it's good.
Yeah, that's right.
Like as it's a procedure.
Yeah, as if it's a procedure.
Yeah. I think we'll leave that one.
Well, but conceptually, right? Like, do we own morphine?
Yeah.
Like, are we the only ones? Are we the only ones who are allowed to give morphine? Are we the only ones who are allowed to give oxygen, or like swabs and stuff? Like, like we don't own MAiD. Like MAiD is the thing that I think people can do and not do, and it's not. It should. I completely agree that it should never be considered the responsibility of palliative care to do. Right? You don't go to hospices to get MAiD. You can do MAiD anywhere. You don't need a palliative care physician to do MAiD. Anyone can do MAiD. And so, yeah, I think that needs to be said clearly that we should not own this.
Thank you very much. I think you've seen the necessity to create more fora to discuss these issues. Thank you all for participating. Thank you all for your comments.